femur is approximated in with the acetabulum up here. So, and that's why we don't want people externally rotating, because if you think about the ball of the femur, when you externally rotate, it causes this ball to roll out, and that can cause it to dislocate. So that's the whole purpose of hip precautions, is making sure that the joint stays approximated. So it's okay, in theory, for a patient to do this with their foot, because when the knee is bent, there is no connection between the foot and the hip. It's only when the knee is locked and I do this that my hip actually rotates. If I do this, my hip's not moving at all. Right? So it really doesn't matter that how he's sitting here with regard to his foot. But what we do want to look at is the angle of his femur with his trunk, right? So if Randy can move his arm over here, so here's the midline of his trunk. Here's his pelvis, here's his acetabulum approximately down here, and now here's his knee. Is he exceeding 90 degrees of hip flexion sitting in this chair? That's my question.
No.
To me, it looks like he's awful close, if not. So you may say no, and that's fine. It's like that borderline. So the reason I brought that up is for some patients, you'll come in, they'll be sitting in their chair, and their leg will be up like this. Nobody's even paid attention to the fact that he's on hip precaution and he's exceeding his hip precautions. So if that's the case, the first thing to do is say, oh, hey, Randy, I see you're sitting a little bit. Let me ask you to move your leg out here a little bit like this, straighten it up, and then I'm going to move the leg rest out of the way like this. Okay, can you sit like that? Okay, can you go ahead and put your foot flat on the floor? There we go. So now he's sitting in a more safe position. So just something to think about, real world, when you walk in and you see a patient, assess how they're sitting in the chair, especially if they have hip precautions. Cool? Okay, is geography our friend when we're doing a transfer? This is geography. Is geography a friend or an enemy? Enemy, right? So when we're doing a transfer, especially for the first time, we want the patient to be as close as we can get to the surfaces that we're transferring from, right? Okay, so Randy, we're going to do a transfer from here to there. Does that sound good? All right, can you go ahead and lift this leg? Do you know how to take your leg rest off? So what am I doing?
You're asking if you can do.
I'm assessing his ability to follow directions, right? See how well he does. Does it matter that he's leaning over on this side?
No.
It makes no difference at all, right? Does it matter if he does this with this leg? Can he lift this leg up? His left leg?
Yes.
This is an affected leg. So he can do whatever he wants to with his left leg. It makes absolutely no difference. The hip precaution is for this leg, right? Okay. All right, Randy, we want to get as close as we can to the mat. Are you able to push your wheelchair? Okay. Now I'm watching him. Can you do me a favor and bring this leg out forward? There you go. Hold it up a little bit. Good. Get as close as you can. Make sure it's touching. Now you may not want to do this, and that's fine. You may feel more comfortable just saying, "Hey, Randy, I'm gonna put you over here like this." Whatever floats your boat. Some of them makes no difference. Are you able to lock your brakes now? All right. There we go. All right, Randy. You know what this is? He's a bell. I see. You're wide awake today. How much sleep did you get? Not much. You ever had one of these?
Yes, I have.
When did you have? So I asked the patient. He tells me he's had it. That tells me that he's been through therapy of some sort, right? Why did you have one of these before?
Yeah, somebody moving me.
All right, so good. So just making conversation, collecting information, stuff like that. All right, so now I've got to get the belt around Randy, right? So one of the things Randy cannot do is he cannot lean forward too much, right? So how do I get this belt on down his back?
I would slide his butt forward.
Okay, so Randy, can you slide your butt forward in the chair for me? Okay. Now, one of the things we notice, can you do me a favor and bend this leg? All right. So if Randy is sitting like this, which is fairly normal for a person, how forward can Randy sit?
Not
more than
Not much, right? Just 90 degrees, right? So you're looking at the angle here of the patient's femur and the midline of their trunk. So about right here is where he can sit, right? So he's okay now, but if Randy started to lean forward like this, he's violating his hip precautions. And I'll be honest with you that in 20 years, I've never actually known a patient who dislocated their hip. I've heard of people having it, but I've never known of it. So sometimes hip precautions, they're important, but they're not like, if he goes to 91 degrees, it's not like his hip is suddenly going to explode and pop out of his joint or something like that. You know. But I have heard of patients dislocating their hips before and having to go back and get a revision. All right, so I need to put the gait belt on Randy. All right, Randy, I'm going to put this gait belt on you, all right? Now, a lot of times I see you guys, when you put them on, you have it up in the back and down in the front. Don't do that. Make sure it gets all the way down around the patient. Now, Randy's a big guy. He's got a gut. I got a gut. No problem. So if I put this up here on Randy, the whole purpose of the gait belt is not to control his shoulders or his upper body. It's to control his trunk, his pelvis. Because where a patient's pelvis is where their weight shifting is. And for somebody standing or transferring, that's the most important thing. Don't put it up under somebody's armpit. Put it down low. For guys, our waists tend to be a lot lower than girls. Your waist, where you gotta put the gait belt, is there for you, up here for you. For Randy and me, it's gonna be way down here. Where I wear my belt, that is my waist. So if a person has a belly, you want to get underneath the belly. You don't get up above it because it's just going to slide up. So you may call it fat, you may call it redundant tissue, you may call it whatever you prefer to call it. Redundant tissue. Now,
Well, sometimes they have stuff there, so.
yeah, so that's a good point. So you always want to ask the patient, and I forgot to because I'm hurrying, is there any peg tubes? Is there anything here, any reason why I can't put a belt on you? Can you feel it as well? Some of the students will do this with the back of their hand because they don't feel comfortable. I'm like, my gosh, you're gonna be wiping their butts probably, so who cares if you're touching their belly or not, right?
That's so fun.
So you can feel right here and make sure. Now, if somebody does have a peg tube right here, and sometimes they can be low, then you would have to go up above it like that. So that's a great point. All right, so good? Quit sucking your gut in, relax. Right. So now, it has to be tight. You guys always, you guys being students, always put them on too loose. They have to be uncomfortably tight, not painful, but tight, right? Does that hurt? Good, so I'm gonna make it a little tighter there. The whole point is this is a safety device. This is just like a seatbelt in your car, right? It's designed to protect the patient, and the worst thing is for it to be loose, to slip, to fall, and then you've done nothing to help the patient. So if it's hurtful, don't do it. If it's a little bit tight, who cares? The patient's only gonna be wearing it for a minute or two. Okay, here we go. Questions? Okay. So now we're gonna use the walker. So you know how to adjust the height of a walker, correct? You know, it's supposed to be about at the wrist. So the shorter the person is using the walker, the less length of time the person is using the walker, the less important the height